Good morning. We're going to review EKG Basics. As we know, February is Heart Month, so we will have a series of education surrounding the heart. So what this is going to look like, every week we'll have a different topic that we're going to cover. This week being our first week, we're going to talk about the basics of EKG, how to break them down, our charting requirements for our patients that are on telemetry, and how do we analyze and read our rhythms. As I said, this is week 1. So our telemetry requirements, we do have an SOP. It's AHO.100.490, which lays out very nicely everything that we need to do for our patients that are on telemetry. First and foremost, we need an order from a physician, a midwife. We need a practitioner level order. And every shift, at the beginning of the shift, we are to call the central monitoring unit and verify our assignment. So once we've checked our orders to make sure that the patients that are on tele have the orders for them, we're going to then call the central monitoring unit to ensure that they have those patients on their assignment as well. And then once per shift, we're going to check our electrodes, make sure that they're placed properly, the leads are placed properly, make sure there's no skin breakdown. If any of them are peeling, we can go ahead and replace them. And we want to check and replace the battery in the telemetry box so that we know it's not going to run out on our shift. And then every 4 hours, we want to complete a telemetry and rhythm assessment in 2 places. So we're going to complete it in Epic under your telemetry flow sheet. And we're going to place the rhythm strip that gets sent to us from the central monitoring unit, place that in the patient's chart, and we're going to sign off that we have reviewed it. When we note that there's a dysrhythmia or a significant rhythm change, we want to, of course, go to the patient. We want to evaluate that patient, see what's going on if we need to intervene urgently. Then we want to notify our provider, which possibly may include rapid response team, but certainly the attending at the very least. Document such in Epic, all of the analyzation and intervention. And we're going to place that printed rhythm in the patient's chart. This video we watched a while back when we were prepping for DNV visits back in the fall. I won't play the whole video, but just know that it is here. It's available. If you would like to watch it again, you can click on this link. It does a really great job of explaining what our responsibilities are for our patients that are on telemetry, as well as the central monitoring unit, and how we can work collaboratively in between departments. So to break down our EKG strip paper, we have the teeny tiniest little square is 0.04 seconds. So 5 of those teeny tiny small squares equal 0.20 seconds. 5 large squares is 1 second. And we look at EKG in 6-second strips. We multiply that by 10, which gives us our 60-second heart rate. And then we have our P wave, which is the beginning of a cardiac cycle. That's when the SA node sends impulses that depolarize the left and the right atria. They should be small and rounded, and 0.5 to 0.25 millimeters in amplitude, which is how high the bump is. And they should be no longer than 0.11 seconds. Next comes the PR segment, which should be flat towards the isoelectric line, or if we're going to compare it to fetal monitoring, similar to what a baseline would be. It's a delay in conduction through the AV node. It's when the atria contract and the ventricles begin to fill. After that comes the PR interval, which is our P wave plus the PR segment. And it's the beginning of the depolarization when the impulses are traveling, the electrical impulses. It's normally 0.12 to 0.20 seconds. If there's a prolonged PR interval, there's a delay in impulse through the AV node, which can indicate a heart block or dig toxicity, possibly. And if there's a shortened PR interval, the electrical impulse is going down an abnormal pathway, something like you would see in Wolff-Parkinson-White syndrome. Next comes the Q wave. So it's the first downward mark after your PR interval, which indicates depolarization of the ventricular septum. And then the R wave is your positive deflection upward, and it's depolarization of the right and left ventricles. Then we have the S wave, which is a negative deflection moving in a downward direction, and it's depolarization of the right and left ventricles. Our QRS complex, a normal range is 0.04 to 0.12. It can be positive or negative or even biphasic. The complex, if it's greater than 0.12, it indicates electricity originating in the ventricles, which we know is abnormal. Followed by our T wave, follows our ST segment. It's repolarization of the ventricles. If we have an inverted T wave, it can indicate ischemia. And a peaked T wave is very common in hyperkalemia. Our ST segment is the beginning of the repolarization of the ventricles. It should be isoelectric, but can be elevated or depressed. If we have elevations in our ST segment, that can indicate infarction, as in ST segment MI, elevation MI, or we can have a depression, which could be ischemia, hypokalemia, or digitalis toxicity. QT interval is the beginning of the QRS complex to the end of the T wave, and it's during the depolarization and repolarization of the ventricles. So normal is 0.36 to 0.44 seconds. And then we have a U wave. It's not always seen, so we may not see it, which is a good thing, because it does have a low amplitude. It's repolarization of the Purkinje fibers. It follows your T wave. If it's elevated, it can indicate hypokalemia or digitalis. So this is a great animation of the heart, the cardiac cycle, and the corresponding EKG measurements. So I think that's a really great visual representation, audio-visual representation of EKG, and how we can determine through EKG what's going on with our patients in their cardiac cycle. What issues are they having? So this concludes week 1 of our cardiac education cycle, and look forward to more in the upcoming weeks. Please let me know if you thought this was helpful, and I look forward to hearing your feedback. Have a great week, everyone.